Hello and welcome. HIV mother and a healthy baby. What's that all about? Because as far as I'm concerned, HIV's got all to do with bloods and fluids, and definitely if the baby is inside the mother and the mother is HIV positive, then by all means the baby should come out HIV positive. But apparently that's not true. But then I can picture this scenario. You go into a doctor's surgery and take a little bit of blood and comes close to you and say, Nana, you are HIV positive. The thought that people are going to know that I'm HIV positive, that there I am, a traditional ruler. My whole village now is going to know that Nana is going to drop dead anytime soon. Anytime we touch him, we're all going to get infected. The stigma will probably kill me before the disease does. However, the news and the stories coming out tells us that that may not exactly be true. But what is the story? I have a man here who is going to educate us today to commemorate World AIDS Day. Stay tuned. When I come back, I'll introduce my guest. My name is Nana Sakwao, and this is PM Express. HIV mother and a healthy baby. Now, I don't know how that adds up, but by the end of the show, we will find out how it does. To mark World AIDS Day, there's a gentleman who's done double time, overtime today. And I say congratulations to him before even the show starts. And that's Dr. Stephen Aisiado, Programs Director, Ghana AIDS Commission. Ghana AIDS. Oh, National AIDS Country Program. Okay. Control program. Let me say welcome and congratulations, because I know you had a long day. Yeah. But all for God and country, we dragged him here in the mid, at this time to come and educate us as well. So what was the day? What did you plan for the day?
Well, thanks for having me, and a good night to our audience. Well, today, as is the case every 1st of December, is the World AIDS Day celebration. It's a good opportunity to once again re-echo the value of all that we've been doing as far as HIV prevention and control is concerned globally, and therefore Ghana couldn't have acted differently. Okay. And so we, within the general melee, had to also do something as a country to commemorate this day. And so, as you are aware, perhaps the overall theme for the world is closing the gap. Closing the gap means that we acknowledge that despite the successes chalked so far, there's still some territories to be covered. There's still a gap. Some people have not been reached. There's access is not total. Coverage is still limited. So we need to close the gap, especially because in 2015 we're looking at a lot of end programs, targets. We think about millennial development goals. We're looking at elimination targets. And so we have to sustain the momentum, try to close the gap, and bring everybody on board. So as a country, we said that we're going to lay emphasis on prevention of mother-to-child transmission, which has been one of our flagships for the past year. Elimination of mother-to-child transmission of HIV, and so moving to zero new infections through that. But the thrust of the theme for us is within the context of what the UNAIDS propounded for the period 2012 and 2015, that there should be zero new infections of HIV, zero stigma and discrimination, and then zero deaths related to AIDS. Now, all these come into play in the specific interventions that we have lined out as a country. We're not doing anything different from other stakeholders in other countries. So strategically, today was to once again re-echo the need for people to still think about HIV. You are aware that we are plagued with Ebola, and it's a current global issue. And because it's hot I mean, people are tempted to think about it and ignore the issues. But all conditions will come and go. What makes HIV unique is the fact that there's no treatment, there's no cure. There's treatment, but there's no cure.
Okay.
And the effect it has on the body. All right, so no matter what happens, it has a very clear relationship also with other conditions. So other diseases will be worse if you have it. And so it will still be relevant until we find some solution in the form of either a cure or a vaccine. All right. Now, stakeholders globally are hopeful that we should be able to end the epidemic by, let's say, around 2030. And so we are thinking about the post-2015 agenda now. And the thrust of that agenda, the motivation is that for the success we've chalked so far, the new reduction in infections, Ghana, for the past 3 years, from 2009 to 2012, managed to reduce infection by 76%. It's the highest. And, among the nations that have, achieved such success. And we have managed to enroll quite a number of people on treatment. And so with all this success, we've reduced for the past decade, our prevalence from about 3.6 among pregnant women to 1.9. If you take the general population, it's now 1.3. So if we have come this far, even with all the challenges with human resource, logistics, funding, I mean, it's still possible to push further and to move things below 1% and to win. And so that, the whole essence of the post-2015 agenda is not to lose the momentum in trying to move to kind of a zero in the transmission.
I mean, I must say, the Ghana AIDS story is one of the few success stories that I think one day we can tell, because I think we've done really well considering, when there were, posters with crossbones and skeletons on it to where we are now. We have moved a lot. But before we continue the conversation, I have an insert to play, and let's watch that and then continue.
This is not difficult at all. The fact that I'm positive doesn't mean that I cannot get pregnant, or anyone who is positive should not be pregnant. The whole thing is about putting an image of persons living with HIV, the image that if somebody is positive, there is hope, there is life, there is everything after HIV. Therefore, the pregnancy that I'm carrying right now doesn't mean that the baby is going to be positive. There are measures in place. I have doctors taking good care of me. I'm also taking the drugs, which helps me to, ensure that the baby will be safe. So this is what we are encouraging right out there. This is what we are trying to tell everybody, that if somebody is HIV positive, you don't have to stigmatize the person. You don't have to throw the person out, but bring the person close to you. Let the person feel part of you. For example, my husband is negative, but he has done everything that he could to ensure that I will be safe, this baby will be safe. My 4 children are also negative, and so we are living. We are having a very happy family that society don't know about, and we want to encourage everybody to know that a person living with HIV is a person living with HIV, and he is a normal human being.
Now, did you, for a moment, think that, oh, I'm living with HIV, so I'm not gonna, conceive. I'm not gonna get myself pregnant? Did you ever,
Yeah, initially when I tested positive, it was like that. It was like there is no hope. In those days there was nothing like even antiretroviral drugs. So you become like there is no hope for you. But when it happened that there is antiretroviral, our capacity was built. We learned more about antiretroviral. We learned what it can do. We learned what even if you are pregnant, you want to conceive, or you can use the medicine for. So it's like it helps us a lot. So the antiretroviral coming in to support persons living with HIV gave us a lot of hope to survive, gave us a lot of hope to ensure that, oh, once you have antiretrovirals, once you take good care of yourself, once you hear totally to your doctors or advices, it's like you are fine, you are okay, you can still go ahead with HIV. There is still life. Initially, I did not thought, but along the line, it came that I have to.
Okay.
So we say that they should encourage themselves, especially husbands, for their wives to do the HIV test, and if it is positive, we can help the pregnant woman and then the unborn baby to come out negative.
Negative husband, positive mother, negative children, it gets more complicated. Well, Doc, how is that possible?
Okay, so it's very possible because, when a person is born, it has to be a joining of two things, the egg and the sperm. Mm-hmm. And for a human being to be formed, and then it continues, the body, it grows, and then that is in. So in the past, people thought that HIV could be transmitted as a genetic material inherent in those structures, but it is not the case. It is not in the sperm cell, okay, neither is it in the egg. But HIV, the virus can be around the semen, that is the fluid that is around the sperm, all right? Now, the other thing is that once that bond comes, there is a possible risk, all right, of transmission from the mother to the baby once the baby is in the womb. Mm-hmm. It will only happen when there's any exposure to other fluids that have the virus. Okay. So you know that when the baby is in the womb, there's some liquid around it. It's called the amniotic fluid. If anything happens, then there should be a procedure which will lead to a mixing of the blood of the mother and that baby's. Then there's a risk. So whilst the baby is in the womb, there is a risk of a transmission to the baby.
Is the baby in the womb not sharing the mother's blood?
Well, but there is a barrier. So there is that placenta, and it's not quite so. But so
it's fairly independent.
It's fairly, yes, yeah. It's fairly independent. But anything that affects the integrity of that placenta now makes room for more exchange, and which will lead to transmission, increased transmission. So any infection and all that. So that is why even the health of the mother generally during pregnancy is critical for somebody who is positive, right? So that is one level. The second possibility is transmission during labor and delivery, because you see, during labor, then you have all the, struggle, the pain, the fluid, there's a rupture of the sac, and then also there could be blood, depending on whether there is any, what they call episiotomy and all that. That procedure is considered to be quite rough, and it is during that period that the risk of transmission is highest, right? So that delivery period, that labor, all right? So in some places, it's because of that, it's said that if you do a cesarean section, then it minimizes the risk. But there are different aspects to it. We don't do that as a policy routinely. Okay. Now, the next possibility is when the baby is born and breastfeeding. Mm-hmm. That is, the virus can be delivered through the breast milk. All right, so by these methods, a mother can transmit to the baby. Now, with all the studies and the evidence, it was various studies that came out. We realized that if we put in specific interventions during this period, pregnancy, delivery, labor and delivery, and postnatal, we can be able to minimize the risk of transmission. Let me state, for starters, that without any intervention at all, if you take 10 mothers who are HIV positive, only about four of them, without anything at all, are likely to pass on the virus to the baby.
Okay.
4, so 40% chance. So even when you've not done anything. Okay. But when you put in those specific measures, it goes further lower. 2%, less than 2%, means that if you take 100. So up to 40 and 2% was a window of hope, and we needed to do a lot. So then all the interventions came in. It's how to provide some form of treatment. It was prophylaxis, one single drug. But over time, it's now like the treatment, 3 in 1. And it's been found to be very, very useful because once the mother takes it, it actually suppresses the viral load. In other words, the amount of virus in the body. And so even where there are other risks, the likelihood of transmitting to the baby is very low.
Does it help with the breastfeeding as well?
Yes, so once the mother is still taking the drug, during labor and delivery, still the viral load is minimal, is suppressed. And then during breastfeeding period, it's also minimized. All right, so now they take it throughout the period of breastfeeding till complete cessation of breast milk, breastfeeding. But next year, hopefully, we will be extending it beyond that period. And that is what we call the option B plus, where they'll be taking it for life. Because the assumption is that this pregnant woman is likely to come another time of pregnancy. In the past, they stop. Then when they come back, they initiate and all that. But now they will continue. So this intervention has been found to be very effective. So far, quite a number of our children, babies, are being negative. And it's by similar considerations that a person who is positive and married to a negative woman can still not be positive, as long as the viral load is low. Right? So one of the new policies is to be able to treat serodiscordant couples. In other words, if I'm the man and I'm positive, my wife is negative, I take medication so that I can minimize the risk of transmission to my spouse, and vice versa. Okay, so, and the point is that that suppresses the quantities of the virus.
Doc, let me take a break here. Now I want to find out, is doctor talking about, because if it's my wife, I certainly don't want to be using condom in my marital bed. So as I've taken my pill, do I use a condom or do I not use a condom? Stay tuned and find out. Well, we just went on a break when the conversation got quite exciting, and I'm sure with all the WhatsApp I'm getting, I'm sure you guys want to know how that is possible. I want to find out too, Doc. But even before we get there, Doc, you've given us, the first one was taking your, is it AVRs, right?
ARVs, yes.
ARVs.
Providing prophylaxis for the mother.
Yeah. And then we want to go to the midwife bit before I come to.
Okay. Yes. All right. So apart from that, the taking the ARVs is making sure that the mother is healthy during the pregnancy period, minimizing other infections and all that. So treating any little infection that is detected, so that there are no problems with the placenta, barrier and all that. The next, and then nutrition, to make sure that they're eating well and all that. The second is managing the labor and delivery, because that is where the placenta rupture, the fluid, the sac is ruptured. And that's where there's a likelihood of suture cutting, the blood, and the baby coming with the face. There could be bruises. So we've taught them specific things as to how to manage it, how to be able to cut the cord, how to be able to manage the afterbirth, how to handle it within strict infection prevention control, standards, and all that will minimize the risk, of transmission. Sometimes, if you are weighing routine cesarean section and doing this, we say the policy is that everybody who will deliver, and there is no contraindication. In other words, there is nothing to the effect that we should deliver apart from the safe vaginal delivery. It has to go on like that, except there is a reason to conduct surgery before you do that. So all these are things that we teach, and the midwives are aware, the obstetricians are aware.
But those who have opted for cesarean, I mean, are their results better than ours, or?
Well, because I said that the risk is highest because of how the nature of delivery by spontaneous, the studies have also shown indeed that if you do cesarean section, it minimizes the risk of transmission. So, but in other countries, they can afford.
Okay.
What access of people to routine cesarean section in Ghana, for instance? Sure. It's very limited. And probably limited to only a few people in the urban setting. You don't even have the requisite staff to be able to do it in the countryside. So if you legislate and say that we should do that, you can't even enforce it. And so if people can deliver spontaneously per vaginum, you give them the opportunity, and then they do that. So beyond that is the breastfeeding. That's the third part. The other alternative to exposure to breast milk is taking formula feed.
Sure.
But that is also expensive. You need not less than about 66 cans of formula feed.
66.
66. And if you have to do that also, you have to think about safe water. You know, and there are specific criteria. So a few people may say that because I know that there is a presumptive risk of transmission through the breast milk, I want to opt for this. But even before we agree, you should meet certain criteria that you can afford, that you not come back and say it's difficult now, that you can have ensure safe water. Because if you don't use safe water to give to this baby, the baby is missing the immune benefits of the breast milk and can have diarrhea and rather die.
It's amazing because as you're talking naively, my mind is going on to the cities and the capital and everything, but there are people, people on the LEAP program who, obviously, this is very far-fetched for them. Even one can will be a problem, let alone 66. So policies should basically be looking at that level and then cut across.
So you are right. That's why our policy is pushing more for breastfeeding.
Yeah.
And that is why we think that even the breast milk is safer now that they are taking the drug. Because once you are taking the antiretroviral, it suppresses the quantities of the virus in the breast milk significantly. So it's easy and safer. Once you take advantage of the benefits of breast milk, remember all the properties of breast milk. It is safe, it's available for the poor person and everybody. So that is the policy. And so that option of the formula is only minimal. And these days, we don't even get people so much who are opting for it. It's easier to do the breast milk because they are taking the antiretrovirals. So if you put all these things together, then they contribute to minimizing the risk of transmission from mother to child.
Sure.
So it's not automatic. In the past, people would not take care of their babies well. They would even abandon them because they were not aware. In fact, people will not even risk getting pregnant because they were told you are HIV, you give it to your baby.
We'll do the stigma.
But it's no more the case.
Because the stigma is a whole subject on its own. I think the stigma even kills more than the disease itself. But, Doc, with regards to sex, if this woman is positive and the husband is negative, so, if they want to have sex, then what happens? Okay,
we teach that as much as possible, they can minimize the risk. All right, so they should have protected sex. They should use the condom. But because of the desire for pregnancy, they can take advantage of the unsafe period of the woman. And we teach them specifically we need to teach them when is the unsafe period, during which period they can take away the condom. Now, during that period, we teach them how to have better sex, well lubricated, so that it will minimize risk of bruises and all that. Then just after the period, unsafe period, they go back to the condoms.
Okay.
Right. The other alternative is to do what we call sperm washing, in vitro fertilization for such a couple. Then it means that throughout they will be having sex with condoms to prevent risk. So that when they want to get pregnant, we can harvest the semen, we can do the washing, we can insert it to the baby, the woman, and then they can get pregnant.
Okay.
Right, so that's it. But the added benefit of therapy is that once a person is on treatment, the one who is positive, it reduces significantly the risk of transmission to the partner. So if you add that to the condom, then the risk is even lower. Even if two of them are positive, we encourage condom use because they can reinfect themselves.
What does it mean?
Reinfection means I am positive, your spouse is positive. We still have HIV. The more I give it again to you, we are increasing the quantities of the virus in our body, and that can enjoy your immunity, your defense harder. Apart from that, there are two types of HIV in Ghana. In fact, the whole world, type 1 and type 2. If you have type 1, it's possible you can get type 2 as well. If you have the two, it's double silencer. It affects even the drugs you choose. It limits you in the terms of the medications we can give you. So we don't want that.
Okay.
All right. So we'll still encourage you to use a barrier so that you don't reinfect yourself, because it increases the titers of the virus in your body, and that can push your immunity down further and faster. All right. So that's what we want to prevent. In the new guideline, one of the criteria for starting treatment will be a discordant couple, irrespective of your CD4 count. All right, CD4 is cluster domains. Is the cells, the number of white cells in your body is a measure of your immunity.
Okay.
So depending on the level, we have to start you. Currently, if it's less than 350 cells, you are eligible to start medication. We'll be moving it to 500 so that people can start earlier, because the studies show that if they start earlier, survival is better. All right. Now, in addition to that, if you have any other disease like hepatitis or tuberculosis with HIV, you also are eligible to start. We add this to what we call the WHO clinical staging. There are 4 stages. If you find yourself in the 3rd and 4th stage, and all these stages are characterized by signs and symptoms, diseases, and the doctors and service providers know. What is new is that because we've realized that treatment is prevention and it's minimizing the risk of transmission. If I am positive, my spouse is negative, we start treatment of the one who is positive, irrespective of all the other things I've mentioned, your CD4 count and all that, so that hopefully you reduce transmission to the spouse. Okay, and all this is to be able to minimize the risk of transmission in the general population.
No, I mean, one killer, I don't know if it's a disease or whatever, is hepatitis. But we it doesn't face most people. I mean, people don't care about hepatitis. But you mentioned HIV, and and I'm saying, like, if I went to my village today as a chief and said, "Oh, I got hepatitis," oh, no problem. But if I came the next day and said, "Oh no, the doctor says no hepatitis, it's HIV," they probably distill me and say, "Look, forget it, you're out of it." I mean, how are we going to reduce the stigma?
There are two. They are all viruses, but one, even without a cure, without treatment, can exist and not be harmful to the person. The person can carry it and not have, and even can be negative depending on the person's immunity. The other, which is HIV, doesn't work like that. It will rather weaken your immunity, and there is no cure. All right, and that, even if it doesn't kill you immediately, will eventually kill you if you don't take anything. And so that is a problem. Now, the other issue about the stigma is how the epidemic started. It was associated with immoral behavior and all that. And so everybody who had it, was tagged with something negative. And that has contributed to the stigma today. Remember also that in the West, it was mostly first identified amongst men who had sex with men. So homosexuality and all that. So that has been one of the reasons, okay? And because we all knew that once you get it, it's a death sentence in the past, a decade ago. Nobody wants to be associated with HIV. And remember that once there's a condition like that, and ignorance adds to it, is worse. It's like the current Ebola. People are running away and all that because of the added ignorance. People didn't know how you get it. And remember that this goes to the core of human behavior. The root of procreation, okay, sex, through which we all came and all that, is the reason that we have said is the source of this infection. And so it was a major impact, a problem to the whole world. So that all that had contributed to the stigma. And to a very large extent, subtly also discourage people from wanting to know their status and all that. But thankfully, over a decade, with the treatment and all that, people are confident. You saw the ambassador. And when we hear such things, we are happy. It's tribute to our health workers, because their effort is being rewarded by the response of these people. And that has minimized the stigma significantly. Because in the past, if you showed up as HIV, people knew you would die. Your family will be stigmatized. Even your funeral will be stigmatized. Now people can show up confidently, even go on demonstration and everything. It's because it's not a death sentence any longer. It's like diabetes. If you have diabetes and you are taking medication like hypertension, you're taking medication, and you take it religiously, you will be well. You continue to take care. So that is where the third component of the zero comes in. Zero deaths related to AIDS. People should be able to live if they are taking their medications and die from other things, not from the HIV itself. So we believe that with all that effort, the stigma, should vanish. But remember that there is some history to it. People still have doubts. In fact, I spoke to some people and they don't even believe this HIV thing that is really real, and so on and so forth. And they think it's a magical thing. People have myths about how you even get it. It's some wonderful thing. We were in one workshop and someone said, if you urinate behind somebody's house without permission, you can get HIV.
Oh dear.
If a man is having sex with a woman and the woman coughs into the face of the man, then you get HIV. You see, they're not thinking about the sex itself. All right, so there are all kinds of things, to the extent that part of the stigma is that even somebody who sells vegetables should not sell, because if you buy the vegetables, you get HIV. Some people even have believed that if there's a teacher who has HIV, we should stop him or her from, because you can catch it by some wonderful. No, it's not the case, and it's no more the case. We keep saying that hugging, shaking, even kissing, will not give you HIV unless there's exposure of blood, So you can eat with the person, you can shake hands. It's not like Ebola. You will not get it. It's not magical. You need to make the effort. In fact, I will tell you that people make the effort to get HIV. Because we did a study in the tourism industry, and people were willing to pay more to have unprotected sex. And the sex workers who are aware and who take the measures will charge you more because they know the risk. So if you use a condom, it's less charge. If you want to have unprotected sex, you pay more. And people are willing to pay more and get it. All right, so you can tell the effort a person has to make. That is the adult. So our passion about the children is that if you compare, an adult will do anything possible, knows that this is fire, will step in the fire. But the child is innocent. The pregnant, that baby in the womb, didn't determine, it's whatever in the world. So we think that if we can prevent them from being positive, it's better. Adults have a limited period compared to a baby biologically, all things being equal, will stay longer on treatment. It's more difficult if the baby is positive. So if increasingly we can minimize or eliminate totally transmission from the mother to the baby, then gradually we'll get a generation of children.
Is that where the condoms distributed in school comes in, or?
Okay, condom distribution in school is about the youth and about the young people.
But once you protected them from the youth, you might as well, from the womb, you might as well, keep them safe.
Keep them safe. Okay, so as part of PMTC strategy is to make sure that there is a prevention amongst the youth and women within the reproductive health age group. So primary prevention, and that is where condoms will come in. That's where abstinence will come in. That's where delaying early sex will come in.
Look, I want to take a break, but when I come back, I want to find out, because we are also a society who, don't want to do sex education, because I'm Muslim or because I'm a Christian and, she's underage or he's underage, and therefore we bury our heads in the sand and assume that, they are young, they don't know anything. If only you know what's flying about on their WhatsApp, you would think twice. But I wonder how that conflict between sex education and our own presumable moral education. Stay tuned, we're coming. Well, we've been educated by Dr. Stephen A.C. Adu, and even before the show ends, let me say we are very grateful. But before the break, I was just looking at giving condoms to students, and I know parents and Ghanaians we profess to be the ones who created morality will say no, 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 no. My child or daughter, my daughter or my son is underage, therefore I won't have that. And with or without it, these kids are, are rampant at it. I mean, if there are 750,000 teenage pregnancies, I mean, they are more than at it. So, Doc, I mean, what are the challenges there? Yeah,
they are, indeed. You have highlighted the issue. There are challenges. I mean, the cultural and religious issues, our society, talking about sex is more like a taboo. Adults don't feel comfortable at all, to discuss sex, even amongst themselves, let alone discussing with the children. We have tried to, through the SHEP, the school health program, introduce HIV education. But the biggest challenge has been that parents will say, as for condoms, don't come and distribute it. Because you are coming to teach them, coming to promote. We are aware that they are already engaged in sexual behavior and all that, but what can you do? So it's advocacy. We have to continue to talk to them and to ensure that a time will come that they will understand. But HIV education is not only about the condom.
No, but at what age are we distributing condom? Like from 14 upwards, 13 upwards?
Yeah, because you see, when you check the time of onset of sex, it varies from people. The last survey, behavior sentinel survey, we put it around 17, but it's not 17 now. It's dropped.
Oh,
I mean, it's dropped. Well, and people at 12 years are having sex. So somebody say basic what do you call it? Basic JSS level should be the ideal time. But somebody says no. Then what do you mean? You come to teach them rather to have sex. So that discussion will continue, and it's not easy.
It's a tough one.
It's a tough one. I mean, if I put it to you, you would not agree that we should come and teach your child, how to use the condom, at a very early age, like that. But once there's evidence that they are having sex. So if you look at our HIV Sentinel survey, 0.8% in the last were between 15 and 19. 1.2, 15, 24 years. Okay, so it means that there are people in that bracket who are getting HIV. They're having sex. And we have to face the fact. We need to deal with the cultural
give me those stats again.
And religious barriers. The 15 to 19 years, it was 0.8%. And then if you take 15 to 24, it was about 1.2%. All right, so these are the youth. Yeah, 15 years. So somehow we should do something for them. We're noticing a decline, however, but we should do something for them. I think it should be coupled with all the religious and moral education.
Should it be the case? Don't use it, but if you have to, this is how to do it.
That is certainly how we will push it, because the first is abstinence. Okay, so don't. If you think that it's difficult to abstain, try HIV. Living with AIDS is not easy. Right? So I would think that every young person should find it easier to abstain, not to get it, than to go in and then have to live with it throughout. So but if you have to use it,
Doc, my controversial thing is then in that case is 12 not too late? Shouldn't you catch them younger? Because I think knowledge is power. Should you not catch them younger?
Yeah, okay. Now, there have been other efforts in other countries and studies. I was just studying the Israeli system, and they noticed there were barriers. We need to segment them, even within the youth, the adolescents, and then we look at the older youth, because they all have different differences in the way they think they assert themselves. And we came to a certain conclusion that we need to really involve the parents, because in all communities, the parents are concerned. In Ghana, because if you are a child, you are a minor, you depend on your guardian, even to do HIV test. It's your guardian that has to consent for you because you're a minor. All right, so they have to be involved. We need to reach them, get them to be comfortable about it. Then they can extend the message. Then they can give approval. Because strictly, a few of the parents accept that we are not capable of providing that information. But if we think that it will make a great impact, we give the authority to the teachers, to health workers to provide this information. And as I've told you, some form of education is going on already in the school. Except that when it comes to active promotion of condoms, it is frowned upon by our authorities and the PTAs. All right.
Is it because they don't know the stats out there? Because, I mean, I chanced upon Ghana Health Service survey, which was done in 2012, and they recorded 750,000 teenage pregnancies. I mean, that's nearly 1 million. So maybe we are not telling parents that this is the story out there.
Yeah, remember, how many of them are out of school? People will say that quite a huge number of those people could be out of school.
Well, I mean, I think a quarter of a million was between the ages of 9 and 13 or something.
And all that.
And that's like 250,000.
So, I agree with you. As far as we are concerned, we should break those barriers and education must go. We should tell them the truth and let them know that these are the risks. But these are the choices you have. Unfortunately, all those who are pregnant, I'm sure if they knew that there was a method to prevent, they would have prevented it, and that would not have ended their education. But we still continue to hide under just moral issues. Pastors will say, no, don't come in. But the same people who attend the church, they report the pregnancies and all that. So the earlier we admit that this is going on and we need to do something about it, the better. So that we start the education early, they are empowered to take a decision and they can make the right choices, and then we can minimize this risk. And it's been done elsewhere, and we can also do it. Because I think if we can prevent mother-to-child transmission, as they grow into adolescenthood and all that, we should still keep them negative, as you said. And it's about introducing the education very early so that they can make informed choices. A few of them, in fact, most of them are where they are because they didn't know. And because it's a taboo and it's taboo religious culture, we're still watching and people are, getting infected. But the problem, I think, is also because of our levels. In every country where prevalence is low, people tend to, relax about the issues. If it was very high, it was hitting us hard, as in some of the Southern African countries where the doctor who is taking care of you is also HIV. We'll be serious about some of these. But we are also a victim of our own success. I mean, because that is also even affecting resource support and all that, because it's so low. Your burden is low. So people don't think we should give that much attention. But these are things we need to assure as we move along, together with all the interventions that we are rolling.
Doc, moving forward, are we making this ARVs here, or are we still importing them? Or what?
We're still importing, but thankfully there are 1 or 2 companies that are coming up. They are working through a process to get WHO accreditation. Currently, the major funding source procures from sources that are WHO qualified, pre-qualified. However, we've also sourced from the local companies with Government of Ghana money. And we are aware and working to support them to make sure that they can also produce.
Okay.
And through a collaboration with the West Africa Health Organization to make sure that there is enough commodity in the sub-region to be able to serve the countries as a buffer, where we can get from other sources. So we're looking into a few years, hopefully, to see 1 or 2 more companies joining, because a few have contacted, they want to do that. They will not be limiting themselves to Ghana. They have to look at the sub-region. But for now, we're getting it from other sources, most of the drug.
What's the story with Koforidua now? Because at one point, it used to be, they had the highest number of signboards.
The Koforidua issue has been historical. I mean, we think that what is happening there is because of the whole history behind HIV, how it entered the country, and the focal point, focus. It's still the highest. In fact, the last Sentinel survey recorded 3.7%. 2 years before, the central region took over, but it was reversed again.
Koforidua
came back for the title still. And then it's followed by the Ashanti region. So somehow effort has gone into Koforidua. People have been there, NGOs and all that. We need to do more. We need to find out. We did a study to compare high prevalence areas like Koforidua, Ashanti and all that, and low, like the northern regions, the 3 northern regions. We didn't see much difference in terms of the risk factors, sexual behavior and all that. So that's why we have believed a lot about that. It's more to do with the history.
Okay.
Most of the people who had HIV from neighboring countries maybe settled there early, and sex work and other sexual practices fueled it. And so you have a cohort, a kind of reservoir of people who keep passing it on in the generations, and that is what is happening. But I'm hoping that with the effect of ARVs, hopefully we should see some change.
Moving forward, I mean, what should the average Ghanaian do to help control AIDS and make your program a success? Because clearly you're telling a success story.
Well, first of all, let me use this to commend everybody who has contributed. And everybody means the service providers plus the recipients of the service. And then in between, the managers, the development partners, everybody who provides money, they ought to continue. Where we are now, people keep saying that Ghana has made progress. We've chalked some success. The burden is low, so people are relaxing. But I always say that if you spend money to buy an expensive vehicle, you need money to maintain it.
Yeah.
Right now, because it's not there is no end like a cure. Once you remove your thumb from it, then the thing will bounce back. So we should all continue in our efforts. Those on therapy should help by making sure that they adhere. We've come very far when we didn't have anything at all. If they adhere, then our first line medications continue to be good. They will not fail. And therefore, we don't have to go to second line, which is more expensive and all that. The general public should continue to respond positively. We know awareness is very high. They should translate it to behavior change. The ABCs are still relevant, despite the fact that we have treatment. Beyond that, we were calling on all stakeholders, development partners.
Doc, we've run out of time, so
to provide the resources. All right. We continue to encourage our health workers to be committed. They have done so well. And we need to work a little harder to make sure that we bring an end to this epidemic.
Thank you very, very much, Dr. Stephen Asare, and I'm sure you have been educated. I definitely have. So, do your bit and the stigmatization, reduce it. You're not going to catch HIV by shaking, hugging, or showing love and concern to anyone. As I always say, tomorrow we'll be back to do it all over again, and thank you very much for watching.
Thanks.
Thank you, Doc.